in my biography is actually some drugs that were developed with a small pharmaceutical company that look as though they should be extremely effective, are very effective for a short period of time. Okay? And we've looked at what stops cancer, prostate cancer growth in cell culture models and in animal models. And one of the things that came up this morning that Dr. Weiner talked about was the fact that vitamin D, in fact, is effective. Well, what we've also shown in animal studies and in cell culture studies is vitamin D by itself is not enough. You actually need to have androgens present for the full effect to be effective. So vitamin D as a chemopreventive works well in men who have relatively normal testosterone levels in the normal range. It doesn't work on late-stage disease, where typically it happens in older men or men who have been chemically castrated or physically castrated, and then it doesn't work well at that point. So again, we can point out issues as a molecular biologist as to why things work and why those don't. So during the course of all of this, I realized that what Judah Folkman said a few years ago is curing cancer in mice is really easy. We've been doing it for 40 years. Curing cancer in humans is a much more difficult problem, okay? We have an incredible number of tools at our disposal, but when I look up from the lab bench, okay, and look around at trying to help a population of people, I discover that people aren't genetically engineered rats or genetically engineered mice. They're not cell cultures where we can use a reductionist approach. Humans have an unfortunate predilection for eating different foods, which messes up all of my experiments, okay? So we're trying to do experiments now. You look up and you look around and say, I want to do some experiments to show that vitamin D actually is effective in slowing prostate cancer progression. And it turns out that I can't simply feed them 1,000 units of vitamin D a day or 4,000 units of vitamin D a day to human populations. Simply stated, human populations are already contaminated because a lot of individuals are taking vitamin D over the counter. And so you can't control for these things. And what this does is it points out that we need to have very high-level molecular technologies, but we have to now couch all of our arguments in terms of human populations. All of my mice that I used, by the way, and I apologize, but they're all white mice. It just happens to be the typical model that we use. And there is a species called the C57 Black 6, which we also use, but they don't resemble in any way ethnic or racial diversity. So one of the things I want to say is we have the tools. We have all the next generation sequencing tools. We even know which genes we need to monitor in looking at differences in progression and in metastatic disease. We know which ones are actually good sentinel markers for indolence versus aggressive disease. We probably know which ones to monitor in terms of understanding whether therapies work. The problem is taking those from the bench literally out to the epidemiology, to the population. And this is why coming here for me has been is so important, is because this is where I actually get to look at what the real issues are in terms of a population and doing proper population studies. One of the things that comes out of this very quickly, of course, is I can do an experiment. If I've got all of my mice looking exactly the same, having the same genetic background, and I treat them with a drug, I'm pretty sure I can get very, very narrow standard errors and standard deviations in an experiment. You do the same experiment in a population, and the error bars are huge. Okay, it's epidemiology and biostatistics. But what that actually means is that doing this kind of study, when we go to NIH and other places to do these studies, is the funding levels to do a proper human population are much larger. And answering the questions about nativity, answering the questions about comorbidities like type 2 diabetes takes two things: money to do the experiments, but also the the information at the level of the patient delivery to identify patients and enroll in the studies. We can do all the fancy molecular biology in the lab and have virtually no impact on human health. We publish a lot, but most of the publications, unfortunately, that we publish really don't impact human health very often. It takes a group of people who have epidemiological background, understanding of the community issues, and getting to and from the clinic appropriately. I thought that was very nicely explained this morning. And being able to figure all of that in as confounders in trying to do experimental designs. So the question is, why do we do molecular biology? Because we can develop the tools, but getting the questions is really the key issue in any diversity study. Okay? I'm going to leave it there. I can talk to this. I should point out that one of my students is in the audience, and he's used to listening to me for 90 minutes at a time. So, Maxim, I'm giving you a break today. So if there are any questions, I'm happy to answer them later on.